This is the dorsiflexion eversion test for tarsal tunnel syndrome. This test places stress on the posterior tibial nerve, which replicates any pain or excessive pronation during gait. So for this test, the patient is lying supine. As the examiner, I will be standing in front of the patient at the patient's feet. For this test, I'm going to grasp one hand on the posterior aspect of the heel and one hand on the distal aspect of the toes. For this test, I will be everting the patient's heel and dorsiflexing the toes simultaneously and holding this position for 5 to 10 seconds. A positive test would be any pain that is experienced with the position, which would indicate posterior tibial nerve dysfunction. This is the inversion talar tilt stress test to test the integrity of the calcaneofibular ligament. For this test, the patient is lying supine on the table. As the examiner, I will be standing in front of the patient at the patient's feet. For this test, one hand grasps the talus at the end of the heel, and one hand grasps the leg above the heel, palpating over the calcaneofibular ligament. For this test, the patient's heel is going to be inverted, internally rotated, and held in this position for a few seconds. A positive test would be the talus tilting or gapping excessively or any pain being produced. This would imply a laxity to the calcaneofibular ligament. This is the Thompson test for Achilles tendon rupture. For this test, the patient is lying prone on the examination table, and as the examiner, I'm standing lateral to the patient. For this test, I will be squeezing the calf musculature for the ankle and observing for plantar flexion of the foot. A positive test would be the ankle not plantar flexing, which would imply an Achilles tendon rupture. This is the Lachman test for anterior cruciate ligament laxity. For this test, the patient is lying supine on the table. As the examiner, I'll be standing in front of the patient. For this test, one hand is going to be stabilizing the femur, while my other hand is going to be placed along the tibia right at about the level of the tibial tuberosity. For this test, as the femur is stabilized, I'm going to be drawing the tibia anteriorly to test for any laxity in the ACL. A positive test would be any increased laxity compared to the uninvolved side or the lack of a firm endpoint, which would imply an ACL sprain. This is the McMurray test for meniscal lesions. For this test, the patient is lying supine on the examination table. As the examiner, I'll be standing lateral to the patient. For this test, the patient's knee is flexed first into the first position. My proximal hand is on the posterior medial and posterior lateral portions of the knee, while one hand supports the distal tibia. For this test, 3 passes are going to be performed. For the first pass, with the tibia in neutral position, a valgus stress will be applied to the knee in flexion, and then a varus stress will be applied as the knee moves back into extension. For the second pass, the tibia is internally rotated, and the valgus stress is applied in flexion, and the varus stress is applied in extension. For the third pass, the tibia is externally rotated, with the valgus stress again performed in flexion and the varus test performed in extension. A positive test would be any pain, locking, or clicking in the meniscal area of the knee, which would be indicative of a meniscal lesion. This is Ellie's test for hip flexor tightness. For this test, the patient is lying prone on the examination table. As the examiner, I'm going to be standing lateral to the patient. For this test, the patient's knee is passively flexed, and what we're looking for in this test is a rise in the hip that is being tested from the table. A positive test would be the hip rising up from the table, which would be indicative of tightness to the rectus femoris muscle. This is the sacroiliac joint compression and distraction test. For this test, the patient is going to be in 3 different positions. For the compression, the patient is going to be side-lying on the involved side, and as the examiner, I'm going to be standing behind the patient. For the evaluative procedure for this first movement, I will be applying a compression through the iliac. Now the patient is on the uninvolved side, and the same force, a downward force, is applied through the iliac. For the distraction portion of the assessment, the patient is lying supine on their back, and I am standing lateral to the patient on their side. I will be placing a distraction force over the anterior side of the pelvis. A positive test for any of these tests would be pain in the sacroiliac region, which would be indicative of sacroiliac pathology. This is the brachial plexus traction test. For this test, the patient is sitting. As the examiner, I'm going to be standing behind the patient. For this test, one hand is placed over the acromioclavicular joint, and one hand is placed on the side of the head. For the evaluative procedure, the head is bent to the side away from the area being stabilized or the shoulder that's being depressed. A positive test would be any pain or paresthesia along the side that is being stretched, which would be indicative of brachial plexus neuropraxia. When the head is tilted away, any pain along the side that is being bent is indicative of a tension or stress, while the side that is being compressed results in a compression of the vertebrae. This is the apprehension test for anterior glenohumeral laxity. For this test, the patient is lying supine on the table. As the examiner, I'm standing laterally to the patient. For this test, the patient's arm is abducted to 90 degrees. The elbow is flexed to 90 degrees. I will be stabilizing the arm at the distal humerus and holding the wrist with my other hand. For the evaluative procedure, the patient's arm is slowly externally rotated. A positive test would indicate apprehension from the patient with a feeling that it may dislocate or any pain in the anterior capsule of the glenohumeral joint. Implications for this test include the anterior capsule, glenoid labrum, or inferior glenohumeral ligament being compromised. Apprehension coupled with pain is often associated with a secondary rotator cuff pathology, and pain in the posterior shoulder may be associated with internal impingement. This is the O'Brien test. For this test, the patient is standing. As the examiner, I will be standing in front of and lateral to the patient. For this test, the glenohumeral joint is flexed to 90 degrees and is internally rotated and is also horizontally abducted 15 degrees from the sagittal plane. For this test, the patient holds this position and resists a downward force from the clinician. The test is then repeated with the arm in full supination with another downward force applied. A positive test is any pain that occurs with internal rotation but is relieved with external rotation. Any pain or clicking within the glenohumeral joint may be indicative of a labral tear. Any pain over the AC joint may be indicative of AC joint pathology, and a positive slap lesion is confirmed when the hand is fully supinated.